I mean, I think that's a really interesting point about the different, just about an acute care setting and the AMPAC that works very well in that setting. And you really have to get the buy-in from leadership to implement something like the AMPAC because it's new and it isn't being done everywhere yet. In inpatient rehab, we have another problem that we have standardized outcome measures or standardized metrics that are being used and mandated in inpatient rehab. It used to be the FIM, now it's the QI tool. But we still know that those aren't the best measures for all of our patients. And so how do we get them to implement and collect some of the other more discipline specific outcome measures?
Hi, if I could just add, this is Jake Magel. I'm from the University of Utah, and we're in the process of developing a rehabilitation outcomes database and dashboard that uses the PROMIS physical function primarily. And how we've really gone about it is said that, this is going to help us learn. I mean, I started off at Intermountain and now I'm at the University of Utah. So I take very much an Intermountain approach. We've taken very much, I've taken what I've learned from Intermountain here and really use this to say, what can we learn how can we learn from how we practice and eventually use the data to change clinical practice to become more efficient and hopefully to decrease downstream healthcare utilization. And that's kind of the big picture. And we're still in the beginning stages. We just are starting to roll this out now, but we still have a lot to learn.
This is Jason Benechek. I'm from the University of Florida and Brooks Rehabilitation. And I will tag along onto Jake. I basically learned everything that we're trying to do at Brooks Rehabilitation from Gerard and Stephen Hunter and even Kate Minnick when she started off there. And it's a real challenge to really get buy-in, particularly from the clinicians. And the way that we kind of approach it at Brooks Rehabilitation is first we approach leadership, and we had to get buy-in from leadership first. But then from the clinician's perspective, we don't only present the issue of it being related to patient outcomes. We really want the clinicians to be interested in their own data. So it provides them the ability to self-reflect on where they're doing very well, but also where they can actually potentially do better. So that's an approach that we're using. And I think just like anything, we're kind of learning along the way as well.
Jason, I think I'm not a facilitator, but that brings up a really important point, because I think there's, even in clinicians that I've worked with and experienced, there is actually interest in collecting the measures, but then if there isn't support from administration and connection with researchers, they don't know what to do with it. And then it just sort of becomes an exercise in, yeah, we have data and we've collected it, but how do we use this to, change our practice, reflect on what we're doing, like you're talking about. And so that connection, I think, sometimes between research and clinical practice is sometimes missing, especially if it doesn't involve the administration, if it's sort of ground level initiated clinicians interested in collecting these types of measures.
This is Stephen Hunter from Intermountain. I think that's where the dashboards come in, having the data in a format that's easy for therapists to either filter down so they can look at their department or themselves individually. And then the other thing that we've done that I think has been successful is you then tie those outcomes to goals, so that we have huddle boards, and on every huddle board in every one of our clinics is their outcome goals, is what we're going to do for TKA or low back pain. And so then, if those goals are also just tied to their performance, then they're much more interested in looking at the outcomes, because it may affect their performance and certainly whether they're meeting goals or not.
This is Gerard. The thing I would like to add here in terms of an argument to support a value proposition in collecting outcomes to an administrator at a health system, the thing that has worked best for us is to articulate to the administration that what we're trying to do is congruent with their goals as an institution and their values, but it's congruent with the company's goals, and it supports those goals. It's not something esoteric. And the other point I would make is that to determine value, you have to approach it from who's involved. The patients involved, the payers involved, and the clinicians involved. And the outcomes they connect with those three entities in different ways. And I'm not going to go into that, but it always has to drive for a value proposition. It needs to drive toward cost savings. If you can demonstrate that you are being efficient and reducing costs, and it has an effect on clinical outcomes, that makes a big difference. If it relates to the culture and the goals are congruent with the institution.
So Gerard, I think you raise a really great point about culture of the institution that you're at. And I know a lot of learning health systems are starting to move towards a pro-based culture. So at Mass Gen, there's been a lot of work in the past few years to try to spearhead some more kind of standardized pro collection. But do you guys have any suggestions for rehab clinicians who might be working at health systems that maybe don't have that kind of culture, and how they might go about, that value proposition when that's not already existing? Or do you think that that's too high of a barrier to overcome?
I'm willing to wait if somebody else wants to jump in, but Tamara, I say this with tongue in cheek, okay? And I'd be interested in Stephen's reaction. But, the way, because what I understand you saying is, how do you get this moving, resonating with the clinicians if you can't get the argument or the conversation going with the higher ups? What we did, because we had resistance, okay? You make people jealous, okay? When pockets, hospital departments, and so when they saw some clinicians submitting an abstract and talking about outcomes at CSM, all of a sudden everybody wanted to do outcomes. Not everybody. It was a slow grind. It only took 25 years. So that's my input. Other people would have ideas, but it does motivate clinicians if they sense envy. It also motivated physicians to collect outcomes, believe it or not.
So Tamara, you bring up a great question. I mean, at Intermountain, we fortunately did have a culture that helped promote this, but I think that Gerard brought up a point that I hope people heard, and that is, if you don't have a culture and you need to get funding, and that's what this question is asking, right? It's how can we approach an administrator and convince them to put forth money and resources to collect standardized outcomes, right? So Gerard made a point, and that is, if it aligns with the vision and values of the company, okay, then it's going to get their attention. Let me give you an example. So one of Intermountain's values is to become a nationally recognized healthcare organization. Well, collecting outcomes helps meet that goal of, the executive leadership team. So the first thing you got to do is look at what the executive leadership team in your organization wants and make sure that your ask aligns with those executive, either key process indicators or whatever else it is. When that starts to link and you make that link, then I think you have a better chance of getting administrators to support you.
I think we should move on to the next question, if it's okay.
Can I just bring up one point? There's been a really nice chat in the chat box, and two of the points that were mentioned in there that I think are important to say here is just the use of a champion. So, if it isn't coming from leadership or somebody, if it is just a regular staff clinician who says this is really something we should be doing, that champion can engage people with a grassroots effort and really start small. And I think somebody mentioned earlier, align what you can with the mission of the organization, but otherwise start small, set your goals with one, I have the power to make one change. I'm not going to change the culture of the organization this year, but start with one small change and then work up. And I think that's been effective for us. We have an organization at the Shirley Ryan Ability Lab that has a very much a culture of being a learning health organization or health system, but you know, outpatient department might feel like they're left out from all of the things that are going on in inpatient. So even there's still small things that have to start with a champion.
Great. Well, I think let us move on to the second question. What are the best ways for health systems to partner with researchers, and what are successful models? It's a question near and dear to me. Interested in your experiences.
Maybe I can speak up for just a little bit, just because of my experience. It was nice of Alan Jette during his presentation to talk a little bit about the opportunity that I had to join with what they wanted to do at Johns Hopkins, but didn't necessarily have the scientific support to accomplish. You had Mike Friedman there, who is a manager and not a scientist, but recognized the value of science. And because of CoStar and the funding that was available through CoStar, was able to look out into the country and to try and identify someone who might want to work on that with him. And here I was hiding in Las Vegas without a health system to partner with, and in need of that. And with the support of CoStar, then we were able to make that bridge and to start working together. And so I think one way to go about identifying those partnerships is to work with organizations like CoStar, like Learn, to help make the match. So that's one way to do it. It worked for me.
I know just from my experience when I first came to UPMC, trying to get in with the clinical folks, I worked with their QI teams and you know, offered some free services just to help them start to look at their data and establish a relationship. So I think it's you know, it's really important for the researcher to come in and try to find out how they can help, you know, the system. And then hopefully from that, you can, you know, stronger relationships and more fruitful things can happen.
Hi, this is Pete McMenamin in Chicago at Northwestern University. And I apologize, somehow my video is not authorized to show up. It's being blocked right now, but we're a PT school with a very large research arm, but we never had a clinical arm really until 7 years ago. We developed an alliance with Shirley Ryan Ability Lab. And even though, let's see, I guess, start my video. Okay, good. So even though we're part of this huge academic medical center, we were never really, and we're a department of the medical school, we were never allowed to have a clinical presence for our faculty. We finally did develop this alliance with Shirley Ryan Ability Lab 7 years ago. And now just in the last year, as part of our 10-year university review, we finally got the go-ahead to start developing collaborations with what has now gone from, in 10 years, from one hospital entity, Northwestern Memorial Hospital, to a 12-hospital system around the whole greater Chicago area. So it's really a major strategic initiative that we're trying to build. So, for example, we had no students, we had 2 student slots at Northwestern Memorial Hospital across the street for years. We were able to develop a culture there where finally we got the therapists there to accept the notion that they are a teaching hospital. So we had to, it took me 5 years to really inculcate that. That has now resulted in them taking 23 of our student slots per year. And now as a result of that, we've been able to build an acute care residency. As a result of that, we're now starting to generate a real interest in outcomes. And now that finally this 12 hospital system just in the last year has integrated their Epic system, so they're all under one Epic system, all of a sudden the possibility is there now to collect outcomes or to start getting standardized data collection across that whole system. So our mission now as a department, or our vision rather, is to really to be the academic hub for Northwestern Medicine hospital system. And we're developing links to leadership at the hospital system level, but also we have a meeting next week actually to start developing links with the rehab managers and department heads throughout that system, both to increase student slots, potentially expand residency training to those groups, and also then get a team together to look at common data collection. So it's a monumental kind of strategic initiative that needs to happen. And but luckily, my chair has given me support to do that, and we're making inroads across the system.
Hi, my name is Ed Hurwitz. I'm the department chair at physical medicine and rehabilitation for Michigan. I wonder if I just wanted to share a little bit about the experience of developing learning health system in a department and along this model of the idea of partnering with researchers. We had a strategic planning meeting in 2016, and the thing that rose to the very top was the idea of researchers and clinicians working closer together. So our medical school has Dr. Charles Friedman, who spoke at Learn recently, and working with him, and then working with Claire Kalpakshian. Dr. Kalpakshian is also at the Grand Rounds today. We developed this model of developing a learning health system within the department to, for all the many reasons we all know, but also to respond to this desire for clinicians and researchers to work closer together. When we introduced the model, we got a lot of pushback from clinicians who were afraid, Claire put this into the chat, who were afraid that they were going to be glorified data collectors for the researchers who would go out and publish papers without their names on it and just go off into research land and let them just be collecting all the data. So Claire and I have worked very hard to work with the faculty, understanding that this is a bottom-up kind of thing where we've had the faculty members form teams, meet in groups, form the learning health system around the kind of work that they want to do, and have them understand also that the benefit is not just publishing research papers, but really crosses every mission. So we're having some nice success, and kudos to Claire, who's really building a nice learning health system within our department.
Hi, it's Jake Magel again, and one thing that we've done here is we developed a position for a PhD student that is partially employed by our largest outpatient orthopedic clinic, and so I supervise her, and my part of my salary is paid for by that clinic also, and so we have embedded her within the clinic. And so she's been able to really get to know all the clinicians really well, treat patients side by side with them, and really be a champion when it comes to kind of boots on the ground questions related to the outcomes dashboard that we're developing, and really been able to engage them in clinical questions related to the dashboard and get some projects presented at CSM, and so that's been a real help for us, is having a PhD student whose job it is to be embedded there within the healthcare system and seeing patients and championing outcomes data collection.
And on the other side of this equation, as a researcher who's embedded in a healthcare system, some of the comments in the chat group are along these lines. It's really important to engage the clinicians in our work. And so just like health systems can embed a research student and pay for that student's position, researchers should really value the clinicians' times. I think all too often it's like, great, let's do a focus group over lunch, and it can be perceived that we're adding work to the clinicians. So making sure that when we submit grants as researchers, that we're budgeting time for the clinicians, to have a clinician either on your research team or to pay for them to be a part of focus groups, and really make sure that we show them the value.
Hi, my name's Katie Quatman Yates, and I actually came from Cincinnati Children's Hospital. Now I'm at Ohio State. And one of the things during my time at Cincinnati Children's that I thought was really powerful, they've done a lot of research outside of rehab using learning health network systems. Improve Care Now is a big one that's often mentioned, if you've heard of that. But one of the things that was interesting about changing the culture there is that the system itself invested in getting the researchers and clinicians jointly trained in quality improvement together. So everybody started to value the methodology of quality improvement, as well as embracing the skills of the context in the clinic, but also with designing measures and using analytical skills that the researchers had. So it was pretty powerful to get people working together on a common goal because we were all learning together.
I think that's a great point again, with developing that mentoring culture, because that's where you start getting more collaboration. And we developed a mentoring culture within our PT school here. So every faculty member has a mentor now who's on the faculty to help them advance their career. And then with the development of residencies, we of course had to develop a mentoring system for the residents. But what we found is at Shirley Ryan Ability Lab, that started spinning off, and the mentoring culture throughout the therapy community there started to get enhanced. And now there's actually one person who has a half-time position there who is in charge of physical therapy mentoring to help all clinicians be mentored. And again, then that rubs off into the start to get an interest in collecting data, things like that. So it's really this culture that is synergistic and builds on itself to focus more on professional development of all therapists because they feel they're contributing to something larger than themselves.
I think maybe we'll move to the last question now, which is what kind of barriers have you encountered? And I think this question is specifically about standardized outcomes data collection. And can the group provide any tips on how to overcome these barriers?
Can I start by talking just for a second about one of the things Alan brought up in his talk about Mike's effort at Johns Hopkins to get the nurses to help collect data in a hospital setting where therapists don't see all the patients. Getting the same outcome data on all patients to look at everybody and make comparisons is really critical. And like Alan highlighted, that wasn't a trivial exercise in trying to convince them that that would be a good idea. And so there are a couple of things that I'll share that, as I've talked with Mike and been involved in some of those meetings and seen his conversations at Hopkins and at other institutions that we're trying to help do this. It's key to have an inside person. You need to convince a nurse that this is what they want to do first. And you need to find someone with enough leadership and authority in the organization that they can help drive that change. If it's a PT who's trying to get nurses to do everything, you'll have much less success than if you have a nurse trying to get nurses to do it. And so I think having an insider is one of the keys to that kind of barrier with regards to getting other providers to help collect rehab's outcome.
I'll just add to that and to say that one of the things that's been incredibly important for us has been to just make outcomes data collection as easy as possible for the clinicians and to really do our very best to take it out of their hands and make it a part of the workflow when the patient comes and checks into the front desk, and just working on strategies to create a flow where there's minimal disruption, and it's messy, and for us it doesn't always work, and we're still doing our best to try to make things work the way we want them to, but we're making a lot of strides, but really making the burden as minimal as possible on every single person involved has been critical.
Another thing that is important to think about is what is going on in the clinicians' lives at the time that you are asking them to make a change, and not just their personal lives, but the organization. So for a little while in inpatient rehabilitation, we were still collecting the FIMS. Everybody was switching over to the QI, so we had to document both FIMS and the QI tool. And then the organization had a bunch of initiatives where they were asking clinicians to collect another 5 outcome measures. And so when you put all of this on top of the clinicians at the same time, it is a burden. That Jake used that word, and it's, you can't get away from the fact that when you're asking somebody to change what they're doing, you are burdening them, and you need to kind of consider how you're asking them to do those things. So if you had another thing to add on to all of those outcome measures, then how can you take something of burden away? And one of the things that we did successfully in outpatient was considering when, it was a very bad time to start a new project in the summertime when census was high. but the clinicians just had a little bit more breathing room in January. And so starting things at a time when the clinicians are not already feeling overstressed with their day-to-day responsibilities was a strategy that worked to beat that barrier.
This is Gerard. This is a question in terms of the barriers that comes up quite often. And the point I would make is that if you're asking clinicians to gather outcome data, the feedback loop to them, they have to have the data come back to them, okay? And the data needs to be detailed and meaningful to them so that they can justify that it applies to them. So it has to be detailed, meaningful, and they have to be able to justify that it applies to them. And then when they work on projects, when they work to improve, they can identify that the improvement is local as they go through quality improvement checks. When they intervene and then measure the effect of that intervention so that they can measure quality improvement. If you're asking clinicians just to collect data, that's a tough sell. It has to come back. They've got to get some feedback on a regular basis.
Gerard, this is Matt Briggs from Ohio State. I have a question. I was wondering if you might be able to expand on what you just said in terms of making the data come back and having it being detailed and meaningful enough. I think that's a place where we're at now in trying to, you're not gonna be able to please everybody, right? But I guess if you can give examples of that detailed and meaningful data back to the clinicians.
Okay, that's a good point, Matt. So there has to be infrastructure to support feeding information back to the clinician. This idea that they have to wait till the end of the quarter to see how they're doing, that doesn't seem very reasonable to me. So, you know, we have a system. The therapist can get online. I'm not going to go all through that, but you know, they can get online themselves on the computer, on the system, detailed enough. So you as a clinician, what do you want to know? You know, I wanted to know, okay, on average, how am I doing with low back pain? And this oswestry, this is the tool we're using. And I think it's a good tool. It's meaningful to me. Knowing the average score is good. Knowing how many patients I've seen in the past month, that sort of thing. What are the average number of visits? So getting down into that detail. This is not rocket science. This is common sense that you would just sit there right there in that office that you're in right now, and what's meaningful to you? That's what's going to be meaningful to people, and not making it too complicated. So you asked about detailed. I hope I gave you an example of details. You know, and then you take it and you say, well, how am I doing as an individual? How are we doing as a clinician? How do I compare to my clinic? How do I compare to our region, our system? And you just take it up from there.
I appreciate that. And those are somewhat of the steps that we've been following as well. Yeah. But again, your perspective is appreciated.
Yeah, and I'm happy to talk to you offline if that's not enough information.
I really enjoyed the conversations. A couple things jumped out at me that I would share with the group. The first thing is, I think the breadth of learning health system activity that's going on around the country is really exciting. There's tremendous breadth. And I was delighted to hear about the different initiatives that are ongoing. One of the things that struck me is that there is no one model. The model has to fit the local circumstances. And I think someone has said everything is local when it comes to, you know, getting this kind of work off the ground. You need local champions, you need local connections, and there is no one model. I think Gerard was making that point. Another point that jumped out at me is Gerard, I think, was making the point that the data, if this is going to work, the data has to be sufficiently detailed. It has to be available to clinicians, the users, and it has to be meaningful. And if it's seen as just another task that clinicians are burdened with, it's not going to get off the ground. But you do have to build the culture in your local circumstance. And the collaboration that people have talked about, for those of you who are in academic settings versus those of you who are in learning health systems or in other settings, it's very exciting to hear about the different ways that you have been successful in generating these kinds of collaborations. So I'm very encouraged. And as Gerard points out very meaningfully, this is not rocket science, but it is incredibly challenging to get these systems organized and working successfully. So it may not be rocket science, but it is very challenging. And I think you all have been doing some outstanding work out there, and I look forward to hearing more about it in the future. Thank you.